Thank you very much for including me in the program as an invitee and giving me the somewhat dubious honor of speaking for about 80% of the world's population about the challenges that face them, which are totally different to the challenges we've been discussing and we're going to discuss. My email address is at the bottom of that slide. Happy to hear from anyone with input or gentle criticisms. Disclosures, none relevant to this presentation. Just a little history of the World Federation of Societies of Anesthesiologists, founded in 1955 at the First World Congress of Anesthesiologists. As you can see, the United States did not join. The ASA was concerned, it being the McCarthy period, that the WFSA was a front for communist entities. But by 10 years later, it was apparent we are not a communist entity. And who knows, by next year, this time, Russia may be our biggest ally. We're a federation of national societies of anesthesiologists representing 150 countries. People often ask me, how do I become a member? If your national society is a member, the ASA is a member, you are members, and you are welcome to participate in anything WFSA does. Our programs are shown there, which does include advocacy, and a lot of my time, particularly at WHO, is spent in advocacy, both for the profession and for patient safety. And patient safety is an integral part of all of those programs in their different facets. WFSA is the official voice of anesthesia at the World Health Organization. Put it in WHO jargon, we're a non-state actor in official relations. And what that means is that we do have the right to make representation to the WHO Executive Board at their January meeting, and to make representations to the General Assembly of the World Health Organization when they meet each May. They've whittled the time allowed down from 3 minutes down to about 1 minute, so one has to speak fast and be very focused. And I've had the pleasure, the privilege over about the last decade to be one of the active individuals turning up in Geneva and making a nuisance of myself at WHO on getting anesthesia and perioperative care onto the agenda and the discussion. Many people are not aware of the fact that the WHO is in fact a United Nations subsidiary, and therefore is bound by all of the constraints and problems and fuzziness of the United Nations. WHO cannot mandate anything. All it can do is highly recommend, or suggest. It's their words. Highly recommend would be the equivalent of mandatory, but they cannot mandate. United Nations would love to mandate peace in Ukraine or the Middle East. They can only recommend it, and they have no ability to enforce. So in terms of patient safety, they can make lots of recommendations. They can create tools. They cannot enforce in any way. This diagram's from an article, a review of ours on the mess that is global opioid regulations, which may give you some insight into the two opioid crises we face in the world. We focus on one. The other 80% of the world focuses on the other. And there is a dynamic tension between the WHO on one side and the Commission on Narcotic Drugs. WHO interested in the healthcare perspective, the CND and its subsidiaries largely populated by law enforcement people. So we're about how do we use poppies for the benefit of our patients, and they're all about how do we burn all the poppy fields and bomb the hell out of the Taliban, who are largely funded by making and selling poppy products. If we look at preventable medication errors in low resource settings, we see a very, very different picture. The report from these 26 hospitals, about an 8% error rate. 83% of them we would view as preventable. But look at the failure to rescue, a death rate from medication errors of 30%. That is astonishing. And the authors of this article believe that's an underestimate, which I believe is true. The vast majority of countries cannot count births and deaths. Hard to know who's around and what the actual mortality rate is. There are startling reports of a discordance between a ward log of deaths and the mortuary rate. How do 30% of the patients disappear without going through a mortuary? Somewhere out of a back door. And what are the factors? The factors should be familiar to all of us. It's the usual culprits: lack of training, lack of supervision, no protocols, no policies, and inadequate communication. No different in that regard. The WHO now has a panoply of medication safety recommendations and resources. They are wonderful resources. The WHO makes all of their products free. You don't have to register. You can just download, and they are incredibly useful and well made. But anesthesia and perioperative care is not there. And over the course of about 3 or 4 years, they were persuaded that maybe there should be something. And I thank Karen Nanji for taking the lead in putting together a multinational document that is, Karen, I assure you, slowly moving through the endless bureaucracy of the WHO. Karen also won a WFSA Innovation Award to do a global Delphi so that we could create medication recommendations structured by country or region finance. Rita has just spoken about barcoding. There are many countries where a piece of tape and a pen to label a syringe are not available. And they view their biggest challenge as, how do I get a syringe that I didn't use on the last patient? So different priorities, similar issues, very different challenges. And we hope this kind of structure, moving things forward in a progressive fashion, will be helpful. Many countries have essential medicine lists. Interestingly, the 2 English-speaking North American countries, much of Europe, Western Europe, have chosen not to have essential medicine lists. I'm sure there's a very good reason that we could hear from the FDA or ISMP or others on why we don't believe in essential medicine lists as an important driver. The WHO does have a model list, as they call it, comes out every 2 years, and it does include a couple of pages of anesthesia medications. I'm currently in the process of leading a global review on these medications to report back to WHO so they can consider if they want to make any changes. Making changes essentially involves the equivalent of a Cochrane review. It's a pretty high standard of expectation to justify change. At the top of the screen, you'll see the #1 drug is halothane. And I hear a couple of sniggers from behind me. Yes, some of us have used halothane in our careers, but probably nobody in this room is using it. Halothane remains a very important drug in many parts of the world. This is a crude survey that we just did. This is out of a letter to the editor of mine that's currently in press. These are some of the countries where halothane is still used. In general, not at the major teaching hospitals, but in the rural communities. And one of the startling problems we've just run into is one of the major manufacturers has decided it simply ain't worth the money, and without informing anybody, just ceased production effective last December. I assume they informed whoever their distributors may be, who see no reason to inform anybody else. So I think what we need to put in place, at least in relation to industry, is at least a moral obligation to inform end users. And in our case, the best way to do that is through national societies. The company is going to stop producing whatever it is, piece of technology or some medication. If they're going to send a note to their distributor, CC it to the National Society of Anesthesia or just simply to WFSAHQ.org, and we'll do it for you. We also need some simple metrics. We've worked on modifying some metrics that were laid out by the Lancet Commission on Global Surgery in 2015. And although most people see these kind of national reporting metrics as pretty dry, in the case of the Lancet Commission metrics, they are actually ultimately about patient safety. And the thinking in putting these things together is what is accessible by every country, not just our country, but what can every country do? And the crudest indicator of patient safety is counting dead bodies. It's horrible to think about it that way. We're here to talk about the nuances and finesse, but the reality is, for much of the world, counting dead bodies is as far as they go. What are the components of important? Safe access to get to healthcare, an adequate, well-trained workforce, an adequate volume of experience in order to do things correctly. And patients also need financial safety. Money is a huge disincentive for patients to seek healthcare, but for healthcare institutions to implement safe practices. If we could do all of those, then we would have happy patients around the world. To foster this, at two face-to-face meetings that were funded by Laerdal, we created a progressive disaggregation, really thinking about what should every country be able to report in 2 years, in 5 years, and sometime in the future. We do not include specifically medication safety metrics yet, or some omnibus simple measure other than death rate for patient safety. And I would love to see some kind of metric developed that we can put into this kind of package. We are currently in a discussion with WHO in them adopting this as a recommendation for national reporting on patient safety. So in conclusion, medication errors are endemic globally. Frequency and mortality is orders of magnitude worse than it is in high-income countries. WHO has a huge portfolio of resources on medication without harm. We're hoping it will soon include a very nice, straightforward document on the perioperative period. WHO cannot mandate or enforce or punish. We have to do that ourselves. An income-linked set of medication safety recommendations would be helpful, thinking along the lines of they need to be accessible metrics, they need to be comparable, everybody understands the definition, and they need to be actionable or utilizable. And I would just remind you that September the 7th is World Patient Safety Day. The United States government, in fact, all 194 governments voted in favor of this about 5-6 years ago. This year's theme is diagnostic safety, but I would encourage all of you at your own institutions and us as a collective to make a noise on September the 17th about patient safety. Thank you very much.